In this section, we will talk about rapid sequence induction intubation, a technique of induction intubation which is practiced in individuals who are at more risk of aspiration. Now, non-rapid induction intubation, in this we do the induction by giving anesthetic agent, then we check for bag and mask ventilation, then give neuromuscular blocking agent, and then again do a mask ventilation for 3 to 5 minutes for the effect of neuromuscular blocking agent to come, and then do laryngoscopy, intubate, and then inflate the cuff. So from induction to the inflation of cuff, that time period, the risk of aspiration is there in the patient, because when you induce someone, the airway reflexes which protect us against aspiration is lost. So from induction to the inflation of cuff, that time period risk of aspiration is there. And in patients who are more at the risk of aspiration, we need to practice the technique which protect against this aspiration. And that is what is rapid sequence induction intubation. So in this section, we will talk about the indications of RSII. We'll talk about the steps. We'll talk about what is the controversies associated with, and what is modified RSII, and what are the complications which we have to look for and prevent it from happening. Apart from this, we will also talk about rapid sequence intubation, which is done in emergency patient, trauma patient, in whom we just have to secure the airway as rapidly as possible, right? Rapid sequence induction intubation is the term which we more use in case of general anesthesia, when we are giving anesthesia to a patient who are at a higher risk of aspiration. And rapid sequence intubation is the technique which is similar to RSII. In this, we have to secure the airway in the patient who are at a higher risk of aspiration, right? I mean, RSI is not done for general anesthesia, right? So, rapid sequence induction intubation. Rapid sequence induction intubation. So, as I said, rapid sequence induction intubation, right? Now, this is done when we need to give general anesthesia to a patient who are at a risk of aspiration, right? And rapid sequence intubation is done to the, this is an intubation technique done in emergency patient to secure airway who are at a risk of aspiration, okay? In RSII or RSI, we practice certain techniques which minimize the risk of aspiration. So, what are the patients in whom we practice rapid sequence induction intubation? Now, rapid sequence induction intubation is practiced in those patients who are full stomach, who are considered full stomach, that is patient posted for emergency surgery, not adequate RNPO. So, patient who are considered full stomach, non-fasted. Now, patient who are at who have gastrointestinal pathology, patient who have gastrointestinal pathology like gastroesophageal reflux, etc. The patient who have a decreased gastric emptying time, whose gastric emptying time is prolonged, right, as in diabetic or other autonomic gastropathy, hiatal hernia, gastric outlet obstruction, right, and patient with esophageal pathology, bowel obstruction, all are at an increased risk of aspiration. Apart from this, pregnant females from 12 to 20 weeks onward, 12 to 20 weeks gestation onward, they are again at a higher risk of aspiration, because GI motility time is also increased. I mean, GI motility is reduced. So, GI motility time is increased, and because of the gravid uterus after 20 weeks of pregnancy, right, the risk of aspiration, because of the increased intra-abdominal pressure, risk of aspiration increases. Apart from this, other causes of increased intra-abdominal pressure like obesity, like your intra-abdominal tumor, also increases the risk of aspiration. So, in all these patients, the risk of aspiration is higher. The risk of aspiration is higher, is increased. So, RSII is practiced. Okay. So, RSII is practiced. Okay. So, let us extend all these indications. So, what are the patients whom we consider full stomach? Now, patients who are not adequate RNPO. So, patients who have not fasted according to preoperative fasting guidelines. So, what is the preoperative fasting guideline? 8 hours for full fatty meal, 6 hours for liquid or semi-solid diet, and 2 hours for clear fluid. If someone has not let's follow this proper guideline, we consider them non-fasting. Okay, then patient undergoing emergency surgery. Emergency surgery, patient, we cannot put the patient for an adequate hour NPO. We don't have that kind of time. And the trauma patient who at any time had their last meal, if they are we have to take them for some surgery, we consider them full stomach. Okay, so patient who has sustained trauma regardless of intervals since last oral intake, we consider them full stomach. So these are patients considered with full stomach, and we practice RSII technique. Apart from that, gastrointestinal pathology, like patient having gastroparesis, patient like diabetic patient having autonomic neuropathy, or patient on medication causing gastroparesis, like your patient taking glucagon like peptide, which is used for in diabetes and or for weight loss, etc., which increases the gastric residual volume and which delays the gastric emptying time, or patient with small bowel obstruction, patient with gastric outlet obstruction, patient with your esophageal stricture, or patient with gastric reflux disease. Now, gastric reflux disease, we need to take proper history when we are taking the history of the patient, proper history of patient against the history of heartburn or history of regurgitation, whether some active symptoms are present or not. So we will just elaborate a little bit more on gastric esophageal reflux disease patient whom we choose for RSII. So in all these patients, we can consider RSII. Now, apart from this, increased abdominal pressure. Patient with increased abdominal pressure, as we already discussed, the pregnancy after 20 weeks of gestation, ascites, patient having ascites, or any severe obesity or intra-abdominal mass. All these patients are considered high risk for aspiration. So how do we select a patient having gastroesophageal reflux disease clinical features? Like when we do the PAC, we should ask, do you have a history of heartburn, or do you take any medications, right? Any medications to prevent these heartburns or dyspepsia, or do you have, let's say, history of regurgitation? So if patient is having active symptoms of gastroesophageal reflux disease, in them we can consider RSII. Or if patient is on a proper medication or is a properly diagnosed case of gastroesophageal reflux disease, we can practice RSII in them. But before planning for a rapid sequence induction intubation, we need to judge these patients against any difficulty in securement of airway, and the approach should be individualized. It should be balanced, whether that risk of aspiration is higher or risk of difficult airway is present in these patients. If both the risk is there, the risk of difficult airway and risk of aspiration both is there, then according to ASA guideline, awake intubation should be practiced, not RSII should be practiced. So in patient with gastroesophageal reflux disease, right, decision to perform RSI, right, it should be individualized, should be taken on the basis of patient's general condition. So we need to judge, we need to balance, this is based on degree of symptoms of GI reflux disease, degree of symptom, and risk of difficult airway and risk of difficult airway, right? So if a patient just have a complaint that after taking spicy food, right, patient, patient, I have heartburn or regurgitation, well, I would not go for RSII in those patients. And maximum patient you give this kind of complaint, let's non-specific complaint that I take spicy food, then I have a heartburn. Now this is not diagnostic of gastroesophageal reflux disease. Okay, so in this patient, I would rather go for a general induction intubation, right? So for patient with GRD, what kind of patient we need to select for RSII? Patient with current symptom of active reflux, patient with current symptom of let's say active reflux, like patient having regurgitation, heartburn, or need to sleep with head up to prevent the passive regurgitation, patient on heavy medication antacid medications, right? Patient who have significant symptom of acidic reflux prior to starting antacid medication. So patient is on antacid medication to prevent this reflux and was having heavy symptoms. Now, patient who believe that symptoms of reflux will come back if their antacid is stopped, if antacid therapy is discontinued, or in patient who have, let's say, who have hiatal hernia, or who is a diagnosed case of GERD on endoscopy. So a diagnosed case of GERD on endoscopy. In these GERD patient, I would go for rapid sequence induction intubation, not for simple non-specific complaint like having heartburn on spicy foods, etc. Okay, so we need to select our patient on the basis of the symptoms that their patients are having, and any risk of, and what is the potential risk of aspiration, or whether a difficult airway is associated in them or not. So in case if a patient has a risk of aspiration, and patient has difficult airway as well, what does the society recommend? The society recommend that we should go for awake intubation. Now, a lot of patient you will get, they are on antacids, right? They are on antacid, the GERD patients, etc. So what is the recommendation of patient on antacid? They should continue their medication till the day of surgery. They should never stop their medication. And we have different group of drugs in this antacids. Like we have the clear non-particulate oral antacids like sodium citrate, etc. We should know at what point of time when we give it to the patient, the maximum benefit is there. So sodium citrate, if we just give 30 ml of sodium citrate just before induction, right, the risk of aspiration would be less, because the pH of the GI tract would be changed. It will increase the pH. So 30 ml orally just before induction for maximum benefit, right? It will decrease the risk of aspiration pneumonitis by increasing the pH of the stomach. Then H2 receptor antagonist. H2 receptor antagonist like cimetidine, famotidine. Now, if patient is on oral therapy, the maximum benefit is on 2 doses. One dose 1 day prior at the night of the surgery, and 1 day and the other dose at the morning of the surgery. If patient has forgotten to take his oral antacid, then just one IV dose 30 to 40 minutes prior to surgery, right? IV dose, that is 40 to 90 minutes prior to induction, would give us the similar kind of benefit. So 20 milligram IV 40 to 90 minutes before induction, or oral night before surgery, or and morning of the surgery. This has the equivalent effect. Then patient on proton pump inhibitors. Again, 2 oral dose will give maximum benefit, one night before surgery and on the morning of the surgery. And if patient has forgotten to take his oral dose, then I can give IV, and IV should be timed. Your IV should be timed 60 minutes prior to surgery, 60 minutes prior to induction. Patient on metoclopramide, the prokinetic agent. Now, metoclopramide should be given very carefully, right? Because the clinical features of tardive dyskinesia, etc., is seen with it if given very rapidly. But it has several benefits. It increases the gastroesophageal junctions, let's say the tone of the GI junction, gastroesophageal junction, etc. So decreases the risk of aspiration, plus it is antiemetic as well. So metoclopramide is a good drug which we can give, but it should be given slowly over 1 to 2 minutes, 10 milligram, and that should be given 60 minutes before anticipated induction. So for the maximum benefits of antacid, their dose and the timing should be properly planned. And if a patient is on antacid, their dose, we should give the patient instruction to continue with their antacid. Okay. Then patient taking glucagon-like peptide-like receptor agonist, that is GLP-1 receptor agonist. Now, example of this drug is semaglutide. Now, drugs like, if a patient is on drugs like semaglutide, now this is used in diabetes, or this is used for weight loss and for several other reasons as well. Now, these drug causes gastroparesis. It delays the gastric emptying time and increases the gastric residual volume. And there is not lot of study which tell us the best time when we have to stop to minimize their ill effect. Some society says that 24 hours prior to induction, we should stop the last dose of your glucagon-like peptide receptor agonist, but still it is not a clear-cut indication. So if my patient on glucagon-like peptide 1 receptor agonist is there and is complaining, has giving me the symptoms of heartburn, regurgitation, etc., now I would cancel the surgery, because that patient is at a higher risk of aspiration. I would increase more time between the last dose and induction of anesthesia. So I would cancel the surgery. Or if I have to take the patient for surgery, I would practice rapid sequence induction intubation to minimize the risk of aspiration. So these drugs like semaglutide, etc., increases the gastric emptying time, right? Or increases or delay, whatever you want to write. Increases gastric emptying time or delays gastric emptying time. So increases gastric residual volume. So there is increased risk of aspiration. So in these patients who are on these drugs, right, we should always ask for the symptoms of regurgitation or heartburn, etc., right? And some societies recommend a gap of 24 hours between last dose and induction of anesthesia. Or if I have to take a patient, I would go for RSII technique to minimize the risk of aspiration. Okay, so how do I prepare a patient for anesthesia for RSII? So if I have to take a patient for RSII, how do I prepare it? Same like any elective induction intubation preparation. We have to do and one very important thing, I mean, same like any other case, but one thing which we do routinely also, and I'm emphasizing here, you do it in a more planned manner, the airway evaluation. Now, airway evaluation is very important before RSII. You know, when we do elective induction intubation, before giving the neuromuscular blocking agent, we do a check bag and mask ventilation, which is not done in RSII. So if after induction and giving neuromuscular blocking agent, I am not able to do a mask ventilation, right, the risk of aspiration and the risk of, like, I will not do mask ventilation and I'm not able to intubate also, right? Then in that case, difficult airway would prolong the timing for induction intubation, and the risk of aspiration would also increase in the patient, right? So proper airway evaluation, and as I said, we need to weigh the risk of aspiration and risk of difficult airway, and we have to plan our anesthesia accordingly. If both is present in some patient, we go for awake intubation rather than RSII. So airway evaluation is very important. Airway evaluation. Now this is an important step to help us in making decision, that whether we need to perform RSII or not. Okay, if there is a difficult airway, if difficult airway is predicted, and risk of aspiration is also there, in that case, we should go for, according to the recommendation, awake intubation, or we should go for modified RSI, right? We should go for modified RSII. So we'll talk about that. So what does the 2022 American Society of Anesthesiologists difficult airway guidelines says? Awake intubation strategy should be practiced when both difficult intubation and significant risk of aspiration is present in the patient, right? Okay. Now, what are the equipments that we need to take care of? Same as our routine induction intubation. So, same as routine procedure. Now, so what do we keep? We keep assorted size of mask, assorted size of laryngoscope, assorted size of tube, oropharyngeal airway, nasopharyngeal airway, right? So, assorted size of standard and alternative airway devices, standard and alternative airway device, right? So we need to keep different masks, we need to keep different laryngoscopes of different sizes, then OPA and NPA, right? We need to keep the suction ready, right? Apart from this, we need to keep supraglottic airway device ready, we need to keep video laryngoscope. So like any other preparation, here also you keep everything ready, right? Everything ready. Okay, so what are the pre-medications that we need to do before RSII? The pre-medication targets against three things. First, it targets against anxiety, it targets against sympathetic response which we can get during laryngoscopy and intubation, we need to blunt it, and it targets against aspiration. So pre-medication may be administered targeting three things: targeting anxiety, targeting the sympathetic response during laryngoscopy, and targeting the let's say the sympathetic response and airway, and targeting aspiration. Okay, so to reduce the volume and increase the pH of the stomach, so targeting aspiration as well. Okay, so what are the drugs that we give? So anxiolytic, what anxiolytic we can give prior to RSII? Midazolam would be the perfect. So midazolam 1 to 2 milligram IV is what we need to give. Then atropine, whether I need to give or not. Routinely, I never pre-medicate my patient with atropine prior to elective induction intubation. Here also, I will see the age of the child. Well, in children, age of the patient, in children, the risk of parasympathetic overdrive is there higher, and during airway manipulation, again parasympathetic overdrive can be there. So in children especially, I can go for atropine pre-medication. So atropine pre-medication can be given in children, and plus in RSI we are using succinylcholine. Succinylcholine is also known to cause bradycardia. So airway manipulation and use of succinylcholine both can cause bradycardia. So in children, I would go for atropine. We all know the heart rate is, cardiac output is heart rate dependent, and time we have very less, especially in the pediatric patients. So only in children I go for atropine. Then opioids. Now opioids pre-medication should be properly titrated. So what are the medication to prevent aspiration? So medication to prevent aspiration, I would give what I have already discussed, the sodium citrate 30 ml just before induction, and the H2 blockers, that is 60 to 90 minutes before the anticipated induction IV if I am giving, or your let's say the omeprazole etc. Again 60 to 90 minutes IV before induction, right? And if I have to give metoclopramide, then metoclopramide 1 to 2 minutes, 10 milligram IV 60 minutes prior to induction. So we can give for antacids. What are the things that we can give? We can give H2 blockers. We can give the sodium citrate that we have already discussed, and we can give prokinetic like metoclopramide. So H2 blockers we can give famotidine etc. that is 60 to 90 minutes prior to induction, sodium citrate just before induction, and prokinetic again 60 to 90 minutes before induction. Okay, now what is the position which we should keep the patient in during RSII? the most preferred position for intubation is sniffing position. So in RSII, before induction, keep the patient in that position. If the patient is obese, make the ramp position. So sniffing position, sniffing position. So what is sniffing position? The atlanto-occipital joint is extended. So extension of atlanto-occipital joint, right? And ramp position in case of the obese patient. So in obese patient, the external auditory meatus and the sternal angle should be in the same line. So this is the morning sniffing position, and this is what we practice routinely. And this is the ramp position which we practice in obese patient. So external auditory meatus and the sternal angle should be in the straight line. Okay. So whether we need to pre-oxygenate before giving the induction agent or not in RSI. Now pre-oxygenation is mandatory in RSI. We give 100% oxygen for 3 to 5 minutes prior to giving our induction agent. So pre-oxygenation is mandatory, and we can pre-oxygenate the patient by mask. We can pre-oxygenate the patient by HFNC as well, though HFNC does not achieve that end expiratory O2 level that quickly, right? So this is pre-oxygenation is must with 100% oxygen. Why do we do this? To increase the oxygen reserve, right? And when we will increase the oxygen reserve, this will prevent the requirement of mask ventilation between induction and intubation. So this increased oxygen reserve will help in preventing any mask ventilation, requirement of any mask ventilation between induction and intubation, right? So we take 100%, we give patient 100% oxygen for 3 to 5 minutes, and ask the patient to take his normal tidal volume breathing, or we ask the patient to take 8 deep full vital capacity breath in 1 minute, or we ask the patient to take 4 deep breath in 30 seconds. Now target of pre-oxygenation is your end tidal oxygen concentration 90%, above 90%. So this is the target of pre-oxygenation. Okay, so pre-oxygenation is mandatory. Now apart from pre-oxygenation, we can also practice apneic oxygenation in these patients. So keep the nasal cannula attached even when we are doing the laryngoscopy, intubation, induction and intubation, etc. So apneic oxygenation can also be practiced. So apneic oxygenation, that is after patient goes into apnea, that pre-oxygenation when patient is actively breathing, and apneic oxygenation is giving oxygen when the patient is in apnea. So apneic oxygenation we can give by nasal cannula. So this causes a passive bulk flow of oxygen from the upper airway towards the lower airway and can cause the oxygen exchange at the level of alveoli. So by nasal cannula at the rate of 10 liters per minute, or we can use HFNC. If we are using HFNC, I can keep very high flow, I can keep 60 liter per minute, okay, or we can use a CPAP also for apneic oxygenation, right? So whatever. So we go for pre-oxygenation and we go for apneic oxygenation, especially if we are anticipating difficult airway. Okay, then cricoid pressure. Now this is a very controversial thing, whether to apply or whether now not to apply. So despite the controversies associated with cricoid pressure, I'll tell you about cricoid pressure, how do we apply, etc. Despite the controversy, I still personally use the cricoid pressure in patient with a higher risk of aspiration with a order to the assistant who is applying the cricoid pressure that you have to release the cricoid pressure if I am finding difficulty in intubation. So if there is a difficult airway and I am unable to visualize the glottic opening, then we can release the cricoid pressure, right? So applying cricoid pressure, studies have shown it has given no harm, though it can make the airway difficult. So if I'm not able to intubate, then we release the cricoid pressure. But otherwise, we practice the use of cricoid pressure. Okay. So what is this cricoid pressure? This is applied during RSI. It was first described by Sellick in 1961. So it is also called Sellick's maneuver. So in 1961, this was described by Sellick, right? In this, cricoid cartilage is pressed backward on the cervical vertebrae. So in this, the cricoid cartilage, which is a ring-shaped cartilage, cricoid cartilage is pressed backward, right? It is pressed backward against cervical vertebra. So how do we start giving it? So if you see this image, we have to press this cricoid cartilage, right? This is the esophagus, which is just behind the trachea. So when I press this cricoid cartilage, the lumen of the esophagus gets obliterated. So when the patient is conscious, at that point of time only, we start applying a slight cricoid pressure, let's say of 10 Newton. And when after giving the induction agent, the patient becomes unconscious, we increase the pressure to 30 Newton. And studies have shown that this much pressure has reduced the risk of aspiration, So we start a slight pressure and then we increase the pressure to completely obliterate the lumen. So this is your cricoid pressure. Now, how do we apply the cricoid pressure? The assistant put one hand below the neck and stabilizes the head and neck of the patient, right? And with his 3 fingers, 2 finger keeping the cricoid in the central position and with the middle finger applying the cricoid pressure, right? We start little pressure, 10 Newton, till the patient is conscious. Once the patient becomes unconscious, we increase the pressure. This is cricoid pressure. So what are the